Hi there, my name is June Davio. Today I'm going to show you a demonstration of reconstitution of a powdered antibiotic, and then we're going to add it, further dilute it in a 50 ml bag of normal saline. We're going to spike that to a 32-inch secondary set, and we're going to attach it to an already existing primary setup. This is a gravity feed, and I'm going to show you the two formulas that go along with this demonstration for successful, safe, competent preparation and administration of this medication. So for starters, I'm going to review my doctor's order. Anytime I receive an order for a medication, there's a set of steps that we follow. If you get into the habit of always following these set of steps, you'll always be really safe in your preparation of medications. So when I receive the doctor's order, and we have an order here for cefazolin 1,000 milligrams IV, you can see that. We're always checking that there are a set of components that exist in that doctor's order. So I want to know that I have the patient's name and their health card number and their date of birth, any allergies. I want to know that the doctor's order has the drug name, the dose, the time, the route of administration, the frequency. I want to see a current date and time, and of course the doctor's signature. When I'm happy that I have all of those components on my doctor's order, then I'm going to compare it to see if it has been accurately and completely transcribed to the medication administration record, or the MAR. So if you look at this top section, that's an example of a MAR. And so I want to know that the doctor's order transcribed over with the drug and the dose and the time and the route of administration, the frequency, the patient's name, date of birth, health card number, allergies. I want to see that that's all there. Furthermore, I want to see that 2 nurses have gone ahead and checked the accuracy of this order, and that it's been signed with their master signature and their initials, and I can see their initials in the date up here as well. So now I know my MAR is safe to use. I can put that doctor's note aside and I can focus on the MAR. Next, I'm going to take out the patient's chart. I want to know their medical history, their medication history. I want to know their history of allergies. Anything that's pertinent. Is there already an IV, and when was it put in? Is it patent in the last nursing notes? Anything pertinent in the chart that I need to know. I'm always checking again for allergies. Then I'm going to review the medication-related information, such as indication, contraindications, action, proper dilution, stability, compatibility with other IV fluids and medications being given, and of course adverse reactions and any nursing implications that I should be aware of before I start to prepare and infuse this medication into my patient. So when I'm finished those things, I'm going to assemble my supplies, but before I do that, I like to always go introduce myself, identify my patient, talk to my patient, and so I'm going to go do that now. As I enter my patient's room, I'm going to do some hand hygiene in front of my patient, and I'm going to start by saying, "Hi Jesse, my name is June. I'm going to be your nurse today. Would you please tell me your full name and your date of birth?" And he's going to tell me, and I'm going to compare that to the name bracelet that is on my patient's wrist. Proper identification of our patient is core to safe practice as a nurse. It's very important. So when I'm done that, and I know I have Jesse, I'm going to explain that the doctor has ordered this IV infusion. I'm going to explain everything that I'm going to do and what that's going to look like, and give Jesse an opportunity to ask me any questions, voice any concerns. I'm looking at Jesse's nonverbal cues to help me understand and assess if Jesse's okay with this or if he's afraid or concerned. While I'm here, I want to check the patency of the IV. So according to agency policy, we're flushing. Perhaps it's every 8 hours we're flushing and checking patency of an existing IV site, or if maybe we have a continuous IV solution running at a certain rate per hour, then we're checking that in our solution. We start at the insertion site. We're looking for any signs of leakage, infiltration. Has that catheter slipped out of the vein and now it's in the tissues? Or phlebitis, is it red and warm? Is there irritation in the vein? I want to see if it's leaking, and of course I want to check for patency if it's not already connected. The fact that it's flowing and dripping tells me that it's patent, and if not, I would be disconnecting and flushing and doing whatever the agency policy is in regards to that. When I'm happy with all of that, now I'm going to come back to my medication room, wherever that preparation is taking place. I'm going to perform some hand hygiene. I'm going to make sure that I have assembled my supplies on a clean surface. Everything we do should be aseptic and or sterile whenever it applies, so that we reduce the chances of our patient developing any kind of infection. Back in the patient's room, I would have checked the tubing again, as you might have seen in some of my other videos. It's very important for us to label the tubing when we initiate it, so that the life of that tubing is clearly labeled and we know when we should change it. That also protects our patient. So I have all my supplies here. You can see that I have another piece of tape ready, because when I do initiate this secondary set, I'm going to label that as well, so that any people coming, nurses coming after me, can check that tubing and see, okay, June initiated that tubing today. It's good for, depending on whether it's continuous or intermittent, when it needs to be changed. So I have my tubing, my secondary set. I have my 50 ml bag. I have a label. I'll need an 18 gauge blunt fill needle. I have a 10 ml syringe. I have my powdered antibiotic with my manufacturer's instructions on top. On back, we're gonna discuss that a little more. And I have my normal saline diluent. So I want to talk about reconstitution and concentration for a second before we go ahead and do the demonstration. It's important for you to understand concentrations. So for example, if we go back to our doctor's order, the doctor wants 1,000 milligrams of cefazolin to be given. And so if I look at my vial of powdered cefazolin and I look at the back of that vial, there are 3 choices that I can choose to increase the concentrations, if you see that. I'm going to choose the very simplest one on the bottom. I think the camera can pick up. I'm going to choose 500 milligrams per mil. If you follow along to the right, it's going to say how much diluent I'm going to add, which I'm just going to turn that this way so you can get a better look. And so the diluent, I believe, is 5.5 mils. And then it gives me a yield at the end, which is just how much do I have in total. Don't worry so much about that. Worry about that first part. When I finish reconstituting with the diluent, I'm going to have a concentration of 500 milligrams per mil. That information is really important for us to do our first formula. So for reconstitution, I want you to understand that reconstitution means we're going to take a solute, which is this powdered antibiotic, and a diluent. We're going to add diluent to the powder. That creates a solution. That is reconstitution. We're going to further dilute, so that means after it's all prepared, we're going to draw out so much medication and we're going to add it to this secondary bag. So that's what further dilute means. The Institute of Infusion Nurses recommend that best practice for us to follow along in our reconstitution and further dilution is to follow the manufacturer's instructions. So I'm going to refer back to my manufacturer's instructions that I've added right here below my MAR. And it gives me a nice set of instructions. It's a recipe for how to successfully mix this medication. And I'm going to talk you through it as we go. And then we're going to fill in the answers as we finish the calculations. So let's go over here and do our math first for the first part of our formula, and then we'll come and we'll prepare that first part. So the doctor ordered 1,000 milligrams of cefazolin. And so desired is what the doctor ordered. That's the first part of your formula. So if I plug in these numbers, the doctor ordered 1,000 milligrams of cefazolin. And what do I have on hand? Well, that represents that vial of powdered antibiotic and the concentration we chose. We chose the simplest one, 500 milligrams per mil, so that's what we have. So have is going to be 500 milligrams of cefazolin in every 1 mil. So quantity represents the other part of that concentration. There's 500 milligrams in each mil. So that's how we plug in the numbers in that formula. easily do that math. That equals 2 mils. 1 mil has 500 milligrams of cefazolin, so 2 mils has 1,000 milligrams of cefazolin. That's the first part of our formula. So now we're ready to go ahead and prepare, and we're going to apply 3 checks and 10 writes to each one of our checks. The first check happens whenever we gather this medication from the drawer, the med card, or the Omnicell, wherever we've gotten the medication. We're going to hold it right next to our MAR, and we're going to start right from the top. Be very systematic in your checks so that you are sure of what you're doing and be present in that. So I'm going to start at the top, and I'm going to say I have the right patient. I went in and identified Jesse. I checked his name in. I know I have the right patient. Do I have the right drug? Yes, I do. It's cefazolin. The MAR says cefazolin. Do I have the right dose yet? Well, no, but I know the math. I know what I'm going to have in a minute, so I can keep going through those checks. I've given the patient the right to education, and therefore he had the right to refuse after I gave him that right education. I checked in my Davis Drug Guide. I know the right reason the patient is receiving this medication, and documentation and evaluation happen at the end and are ongoing. So you can see how those rights apply. But definitely make sure you have the right drug, and of course your right dose and right time and route and frequency and so on. So that's my first check. So now I'm going to go ahead and take the tops off of my diluent and my powdered antibiotic. I'll do a little bit of hand hygiene just in case I may have missed it. And I'm going to open up an alcohol swab. And I'm going to give a good 15-second scrub to each one of those vials. We never assume that they're sterile under the cap. That is our new best practice. So we're going to give those a good scrub. Great. While that's drying, I'm going to go ahead and open up my 10 ml syringe, and I'm going to create that clean little sterile cradle for my syringe to set in as I'm working. And I'm going to go ahead and open up I'm just going to take that right off so it won't fly back on me. I'm going to open up my 18 gauge blunt fill needle that I need to prepare my medication. And I'm going to attach those two. So here's an example of sterile technique. That syringe has a sterile end, that hub has a sterile end. Nothing touches those ends except sterile. Sterile can touch sterile. So now I have a nice closed system. I can set that down inside that cradle where it's nice and clean. It's not setting on any dirty surfaces. And so let's talk about our math again for a second. And let's talk about our manufacturer's instructions. On the back of the vial, we know that in order to get a concentration of 500 milligrams per mil, we're going to add 5.5 mils of diluent. We know from our instructions that normal saline is an acceptable diluent. We have that here. We've swabbed the top. And remember now, we're working with a vial. That's a negative pressure system. So we need to add air in order to change the pressure so that we can withdraw and aspirate the right amount of fluid. So we're going to go ahead and get our 5.5 mils of diluent. I'm going to draw 5.5 mils of air in my syringe. I'm going to pull my cap straight off and away and set it down on a surface so that I can pick it up again after. I'm going to stabilize my vial with my non-dominant thumb and index finger. I'm going to turn my syringe like a dart. I'm going to pierce the top of that vial. I'm going to keep the needle above the fluid. We try not to inject air bubbles into our fluid or into our solutions. My thumb is my powerhouse, so it comes up to the top, and I'm going to insert that air. And then while I have it all in my hand, I'm going to invert the vial, switch my hand around. I'm going to show you that window. You can see the little window. You can see I have my needle well submerged in that fluid, and that should easily, I'm going to stabilize that syringe against my palm, and I'm going to allow 5.5 mils of fluid to fill in there. You can go a little bit past it if you want to. Go ahead, and that's why you need to stabilize it and hold on tight to every part of your setup so that you can wrap that syringe, get the air out, push it back in if you need to, and finish with exactly 5.5. Must be accurate, okay? When I'm happy with that, I'll just turn my vial back. I'm going to pull that syringe out, and I'm going to go ahead and go right to my my vial of powdered antibiotic. Stabilize. I'm going to pierce the top, and I'm going to keep my needle well above. I'm just going to show the camera. You can see in that little window I'm keeping the needle well above the fluid. So I'm going to stabilize it on a hard surface. My thumb is my powerhouse. And you can see now that I'm adding this diluent, but I'm also adding pressure. So you can see that I'm letting my thumb come back off the syringe because I'm allowing the air to escape back into the syringe, but I'm pushing the diluent into the vial. This is really important in your practice so that you don't get spray back of these medications into your face. That can be toxic to you. You don't want spray back, so you're just making sure you get all the air out of there so that you don't get any kind of a spray back into your face. So I've done that. You can see the syringe is full of air. I'm pulling the syringe out, and I didn't get any spray back. So I'm going to go ahead and put one arm behind my back because we never recap a needle with two hands, but we're going to recap this by just scooping it up and putting the cover on, and it can sit in this nice little clean cradle here for a second. And now we're going to go ahead and just roll it in our palms. We don't shake while it dissolves. While we're doing that, or after we finish that, somewhere in preparation time, we're going to do our second medication check. And that requires us actually looking at our vial, comparing it to our MAR, and applying those 10 rights. Do I have the right patient? Yes, I do. I went in and I identified my patient, and I'll do it again when I go back in to attach this medication in its secondary bag. Do I have the right dose? No, not yet, but I have the right concentration, and soon I'm going to draw up the right amount of medication, which is 2 mils, once I have this all dissolved, and so on and so forth. I'm going through those rights. So when I'm happy that every single bit is dissolved, make sure there's no precipitate in your vials at all. You're going to go ahead and re-swab that top, just in case your hands grazed it and contaminated the top. So give that a good scrub again. And then when I'm done scrubbing the top of that vial, and while it's just drying there, I'll make a little space so you can see what I'm doing. I'm going to grab my 50 ml bag of normal saline that I'm going to further dilute according to my manufacturer's instructions. And I'm going to move that in front of me with the ports. You can see these little ports. One is the one I'm going to pull off and spike the tubing with. It's sterile under there. And this other little port is the one that I'm going to actually inject that needle into that port and inject my medication when I'm ready. So I'm going to swab that really well. So that gets a good 15-second scrubbing as well. Very important to always do your best to remove microbes. So when I'm done scrubbing that, I'm just going to leave the alcohol swab right there on it, under the table. You can see the camera's picking up what I'm doing, I think. Okay, I'm leaving that there. You can see that I'm leaving this bag. I'm a right-handed person. I'm going to be injecting this port from this angle. You do not want to be lifting that port up off of the table. This is how you accidentally stick yourself with this very large 18-gauge sharp needle. So I want you to practice keeping the port down and level with the table and coming in from that angle so that you don't pierce yourself. Okay, so that's all ready to go. This is all ready to go. It's all swabbed. So we're going to be withdrawing 2 mils of medication. There's 500 milligrams of cefazolin in every mil. We need 2 mils to get 1,000 milligrams of cefazolin. So I'm going to go ahead and draw 2 mils of air because I'm going to be taking 2 mils out of the vial. I'm going to pull my cap off straight and away. And my sharps container is out of view, but I'm going to be putting this in my sharps container when I finish. So I'm going to go ahead and stabilize my vial. I'm going to pierce the top. I'm going to keep the needle well above the fluid. My thumb is my powerhouse. I'm going to inject my air, and I'm going to move the whole system, invert it. I'm going to turn that window so that I can see it. I've got the needle well submerged in the fluid, and I'm going to go ahead and draw up exactly 2 mils. And so you shouldn't have to take the needle out of here until you're sure you have exactly what you need. Go ahead and flick it, get out any air, inject it back into the vial if you need to. Get out all your bubbles. One little bubble there. There, I got it it out. And this is the point where, while I have the needle or the syringe still in the vial, and I have the MAR with me, and I haven't injected it into the secondary bag yet, this is where I would do my third and final check, and I'd have a second RN check my work. So very important that you have somebody else check your work and that you complete your 3 checks and apply your 10 rights. So I've got my vial that is labeled. I have the syringe now with the exact dose in it. I'm comparing it to the MAR and applying those rights and having a second nurse check that and sign my card as well. So when I'm happy with my 2 mils, I'm going to invert the vial, pull my syringe out, and because I swabbed that port before I did that step, I'm able to move right in here and do that. So I'm going to grab that port with my thumb and my index finger, and the camera's going to close in here so that you can get a really good look at what I'm doing, so that you don't stick yourself or injure yourself. And you can see that I have everything laying down on a nice flat surface, and you can see that little circle there. I'm going to keep the port nice and flat to the table, and I'm going to hold on tight to the little white part of the port, and I'm going to inject that syringe right in there. Use a little bit of your muscle, and you can see the needle is in there now. And I'm going to go ahead and inject my medication. And I'm going to pull that out. And I'm going to go ahead and drop that into the sharps container and dispense of that. Okay? I'm just going to put that right there out of the way. So I now know that I have very safely, accurately, and completely prepared that medication and added it to the second bag. I've done all my 3 checks. I've had a second nurse check my work, and I'm pretty happy with that. So you can get rid of that vial once you've completed that 3rd check. Just rock your secondary bag gently back and forth. Don't shake. You can get rid of your garbage while you're doing that. Then I'm going to fill out my little label. And I'm going to put the drug and the dose and the date and the time, my signature and designation, and of course that second nurse signature and designation would follow. And I'm going to flip my little mini bag over because we never apply the label to the front that designates what this fluid is. We flip it over and we put it on the back, and those just crack. And fix that to the back. Okay, so that's all ready to go and safe. The next part of our demonstration is spiking the bag. So again, you take note of that drop factor number. It's 15 on this tubing. That means that this will administer 15 drops for every mil once we have this on. You'll also note that there's a small little blue hanger in here, and that's going to make a lot of sense when we set up our gravity feed. So this is a small little 32-inch tubing, quite short. Again, I can't stress how important it is for you to remember, and it tells you, that little piece of paper says, tighten all inline connections. That means close the roller clamp as soon as you take this out of the package. You can see it's a very short little 32-inch, which I shouldn't really be saying inches, should I? It's 81 centimeters, but it's 31 inches. That's what I remember. And I'm going to close that roller clamp right away. And you can see it has, similar to the 100-inch that we talk about in my other videos, it just doesn't have the Y valves because it's just such a short tubing, and it attaches to the Y valve on your primary set. So we talked about that in the other video. You can see this little hanger. So I'm just going to set my tubing down for a second. I've closed my roller clamp. So this little mechanism or hanger that comes in the secondary set is for you to drop down your primary set. So you put the hook in your primary solution that's running, and then that's going to drop the primary set down lower. And then we're going to go ahead and take our newly prepared medication, and I'm going to hang that on the IV pole with the label facing me. I'm always looking at that label. I'm always checking my work. I have my new tubing with the roller clamp closed. I have a sterile end, and I have an alcohol swab right here because I'm going to be connecting that end in a second to this first Y port closest to the top of my primary set. And that needs to be swabbed really well to remove any microbes. We're going to do that in a second. But first we're going to spike this little bag and prime it. So the technique is pretty straightforward. We have a sterile spike under that cap, and we have a sterile port under that little blue tab. And so the camera's going to come in here so you can get a good look at it. You're using all of your fingers so that you get really good at using all of your fingers. So my non-dominant hand, or my left hand, is holding the port at the hardest part of the plastic where it's more firm. It's softer up here, it's harder here. And so my thumb and my index finger are holding onto that port. My right hand is holding on to the spike, the chamber I should say, and the spike is, you can see the spike right here. So my right thumb and index finger are going to pull that little blue tab off. So that's sterile. Nothing can touch that except something sterile. I'm reaching this hand in behind me where it's free. I'm going to pull that spike off. Just be careful. Maintain the sterility of that spike. And I'm just coming into that port. I'm keeping everything nice and straight. And it's a push and twist. So at the same time you're pushing, you're twisting. You can see a little bubble. That's when you break through the little membrane that's there. Push that on all the way. To use your muscles. There. So once you have that all spiked, now we have to prime it. And so I'm glad the camera's nice and close. You can stay right up here, Mr. Cameraman, if you would please. First thing that I'm going to do before I prime, and priming means we're going to push all of the air out of the tubing with fluid. So because there's medication in here, we don't want to waste a drop. The trick to a good prime is to go slow. If you open everything up too quickly, you'll get a turbulent flush of fluid, and that creates bubbles in your tubing. So just take your time, and I want you to watch first. I'm going to fill that chamber, and you do that simply just by squeezing the chamber, and then just let a little bit of fluid come in there. Okay, that's enough. We're going to count the drops from there. Then I'm going to hold the tubing over a receptacle to catch the drops, and I'm just going to very slowly turn this roller clamp up, and you watch those drops and how quickly that just starts to fill the tubing and push the air out. So we're just going to slowly turn up the roller clamp. You can see, start right here. You can see how fast that went right through there, and it just slows down a speck as it goes through the roller clamp. You can see it coming right out of the tip there. So go slow. Take a minute to prime so that you don't lose a bunch of minutes trying to get out your bubbles. And we don't want to lose anything, so I'm going to let this come to the end. You can see there's not a bubble in there. And I'm just going to let one little drop fall out, and I'm just going to shut that right off. So that's all nicely primed and ready to go. I'm going to take my alcohol swab. I'm going to go to that first Y valve, and I'm going to scrub that really well. You hear that scrubbing? That's me killing germs. And anybody who knows June knows that June really enjoys killing germs. So I'm envisioning squishing them under my alcohol swab. So a really good scrub. Okay. And then I'm going to carefully remove that sterile cap. And this is a push and twist. That's a positive pressure valve there. We're going to push and twist. Okay. Each time we connect and disconnect that deserves a very good scrubbing before it's reconnected. That's how we protect our patient. Okay, and if I didn't explain well enough in the beginning, let me just go ahead and explain that again. I'm applying the piece of tape that has the date and time that I initiated this tubing. If an infusion tubing is continuous, it's good for 96 hours or whatever agency policy dictates. If it's an intermittent infusion, so that means I'm disconnecting it from any part of its closed system, it's only good for 24 hours, and according to agency policy. And when in doubt, throw it out. Anytime that you come across tubing that has not been properly labeled, you're putting your patient at risk if it's exceeding that time limit of safety. So it's very fiscally responsible as well to label your tubing, okay? So now we have everything connected. We know we have a safe dose. It's so rewarding as a nurse to know after you've done your math and you've prepared and you've done all of your checks and you've applied your rights that you have a safe medication there hanging and you're ready now to just finish your calculation and move on to counting your drops. So we're at the very last stages of our work. So the next thing that I'm going to do is ask you to come back to, for a second, if the camera would just zoom in on these right here, this little section down here below the manufacturer's instruction. The first little blank that you'd fill in says the amount of diluent for reconstitution. And so if we go back to our vial for a second, and you see that in order to get our concentration of 5.5 mils, our concentration of 500 milligrams per mil, we're going to add 5.5 mils of diluent. So you're going to fill in that little part right there. Amount of diluent for reconstitution is 5.5 mils. The volume of medication that is added right there, the second one, to the secondary bag. So that's the syringe that we drew up this medication out of after we reconstituted and added it to that little port, was 2 mils. That's our first formula. So that's where you'd put that piece of information, 2 mils. It tells us how long to infuse. It says that this should infuse over 45 minutes. That's that third little part right there. It gives us an important part of information that we plug into that second formula. And then the last thing we would fill in is what are the drops per minute, and we're going to do that formula right now, okay? So, I'm going to come over here. Stay with me for one more minute. Our volume is that 50 mil bag. That's our new volume. There is 2 mils. We could say 52 mils. You'll get a bit of a decimal point in your calculation. According to best practice, you do not have to add anything under 10 mils to your little 50 mil bag. So we're just going to say a volume of 50 mils. The time has been clearly given to us by the manufacturer's instructions. It's 45 minutes. And our drop factor, I've explained over and over, is that little number on your tubing package. That's 15. And that's going to give us a bit of a wonky number. It's going to give us 16.66 drops per minute. And so if I had a class in front of me, I'd say, can we administer a fraction of a drop? And the answer is no, we can't. So we'd have to round up. So anything 5 and above gets the next number, so we're going to bring that to 17 drops per minute. And as you start to count your drops, and 17 is going to be a bit of a difficult number to count over a minute, you can simplify that by dividing it all into 4 and doing little 15-second increments. And so now we're going to count our drops, and you can be off one either way. Okay? So we're going to come back over to our mini bag, and of course we can add our final answer, which would be 17 drops per minute on our little information sheet that you would pass in on your demonstration day. And so I'm going to come over here again. Everything is all connected. I've dropped down my primary, so this is the one that's going to flow. There's one more bit of important information you need to understand when you initiate a gravity feed. And so the roller clamp for the secondary bag, the medication bag, has to be turned on all the way. So your primary is completely shut off right now. That's the 100-inch primary tubing. That's shut off. Your secondary or your piggyback set roller clamp, you turn on all the way. And if you watch, if I can just get the camera to watch that chamber, I'm going to turn that roller clamp on all the way, and you're going to see that nothing happens. And that's the way it should be. Nothing's dripping out of there. And if the camera would just stay close with me here. I'm going to get my primary roller clamp. That's the one that controls this. Just watch as I slowly start to turn this roller clamp on, the primary roller clamp. You can see those drops start to initiate. So the primary roller clamp controls the drops for the piggyback set. Okay? So we know we need 17 drops per minute, and that's going to give us an infusion time of 50 mils in 45 minutes, sorry. So I'm going to divide that and simplify it myself. So I'm going to count for 15 seconds. I'm going to try and get around 5 drops in every 15 seconds. Great, and I did. So now, after I do that little increment of 15 seconds, I'm going to count for another full minute and make sure that I have 17 drops in every minute, or I can be off 1 drop. It could be 16 or it could be 18, no more. And that concludes. Oh, sorry, that doesn't conclude. I would absolutely come in and check this IV intermittently in the time that it's infusing, and check on my patient and check my IV site to make sure that it's flowing properly, that it hasn't infiltrated, nothing's leaking, that my patient isn't feeling discomfort and pain or any adverse reactions. When it's completed, I would come back in and I would reformulate, switch out this little hanger, raise the primary set back up and re-regulate those drops for that solution. I would sign my MAR after I've given my infusion. I would document in my nursing notes everything pertinent to this, and I would continue to check on my patient throughout my shift to make sure the patient is feeling well, and certainly let my physician know if there are any problems with the infusion or with my patient's care. And that concludes our demonstration for today. Thank you.